Welcome to tonight's Brain Power Hour, brought to you by the Amen Clinic's Brain Warrior Alumni Network. It's a dynamic series of spotlighting Amen Clinic's doctors as they share their expert insights, answer questions, and guide you through powerful practical strategies to optimize your brain health. These Brain Power Hours are just one of many programs offered through the Amen Clinic's Brain Warrior Alumni Network, which is an exclusive community free to all Amen Clinic's patients, former patients, and parents of underage patients. If you're an Amen Clinics alum and haven't yet joined this exclusive network, I invite you to do so tonight by clicking the link in the Q&A. It's a place designed especially for you to connect, learn, and grow together. And now it's my pleasure to introduce to you tonight's speaker, Dr. Jackie Meinhardt. She is an innovator, clinician, scientist whose evidence-based functional and integrative medicine to uncover root causes and treat autoimmune conditions, psychiatric disorders, thyroid and hormone imbalances, digestive and gut infections, and other inflammatory-based illnesses. Trained by Dr. Andrew Hyman and certified by Richie Shoemaker in chronic inflammatory response syndrome, she has also studied under Dr. Dale Bredenson on inflammation's impact on brain health and works closely with Ruth Chris, NP, on embedded infections. She earned her Doctor of Nursing practice from Georgetown University, where her research focused on biotoxin exposure and cognitive impairment, and holds a master's degree in family nurse practice from Georgetown University and integrative medicine from George Washington University. A board-certified FMP and diplomat of ISEAL, Dr. Meinhardt also teaches biostatistics at Georgetown University. Outside of medicine, she enjoys the outdoors, family life, and coaching Riverside High School crew in Leesburg, Virginia. Welcome, Dr. Meinhardt.
Thank you so much, Charlie. I am so excited to be here with everybody and all of our alumni network. The Amen Clinic really does do such a wonderful job of having our patients connected throughout not just the clinic, but the community. And we are so delighted to have everyone here tonight. My name is Jackie Meinhardt, and I will be speaking tonight on chronic inflammatory response syndrome. Charlie did mention that some of my patients are on tonight, which is just so exciting. Thank you so much for supporting the Amen Clinic and in myself. And I'm going to make this really informal. So we're going to be doing a slide presentation, but if you have questions, I have the question and answer scoreboard up, if you will. If you have questions, I'm more than happy to answer them as I go through. And then also at the end of the presentation, I will have my email address and our office phone number at the end of the presentation as well. So I do look forward to connecting with everybody. And again, making this more of a community, the way Dr. Amen has envisioned it. So thank you so much for being here with us. So chronic inflammatory response syndrome. My name is Jackie Meinhardt. I am a nurse practitioner. I work at the Amen Clinic. I'm also an assistant professor at Georgetown University and also George Washington University. I teach biostatistics and epidemiology to the medical students and to the nursing students graduate level. I am a legal consultant through George Washington University, mostly for mold cases and chronic inflammatory illnesses associated with environmental exposures. So think mold, think actinomycetes, think beta-glucans, different types of asbestos, things like that. Charlie went over my education. Again, my heart bleeds blue, as I like to say, from Georgetown, Villanova, and also George Washington. I just have different flavors of blue. And my clinical experience has been close to 30 years, starting out in critical care medicine at Johns Hopkins Hospital, and then, of course, doing really this chronic inflammatory response for the last 16 years of my medical career, really enjoying educating and not just medical providers, but also patients and medical students and nurse practitioner students. Because again, we have to be able to have people see that this illness, once you see it in the community, you'll never not see it. So thank you so much for being here. The learning objectives for tonight, of course, is to define chronic inflammatory response or CIRS. It's also to discuss the pathophysiology and the physiology, the diagnostic criteria, and then also the treatment options that we have. And the epidemiology, chronic inflammatory response, also known as CIRS or SIRS, is really a chronic presentation. It is an illness complex that has lasted for more than 6 months of a time period. It really is, when you boil it down, the physiology of chronic inflammatory response, it's really looking at the immune system has become dysfunctional. Everyone on this phone call has one immune system. In that one immune system, we have two pathways, the innate and the adaptive. CIRS, honestly, is an innate immune system dysfunction. And it typically has a genetic predisposition, meaning that this is an illness that is passed down from family to family, potentially from your mom and dad. That's what I like to say. It's kind of how we are made. And roughly, we know that about 22% of the population, and there is a typo, it's actually 40 million people, not 4 million, but 40 million people suffer from this illness. And historically speaking, many of my patients have heard me say, really, this is about an enterohepatic circulation issue, meaning we call it a remixing syndrome, where the toxins actually never leave our body. So, just a little trivia question: how do we get rid of toxins in our system, right? What you think is an easy question, but it actually becomes quite difficult for some patients to detox. We detoxify our system by urination, having a bowel movement, sweating, breathing, right? So those are all the different ways that we can excrete toxins from our system. And when the enterohepatic system is not working well, you start to see the toxins get remixed into the system. And that is truly a biotoxin illness. There are a variety of toxins, inflammagens, and different bacteria and viruses that impact our immune system and create this chronic inflammatory response. I've had them listed here, but many of them are things that you may or may never have heard about before. For example, like volatile organic compounds. When you think of when going into a new building and smelling that chemical of the floors, right? Or the paint fumes. Those are VOCs, different building materials. We think of bacteria, virus, parasites. COVID is the newest one on the block that we all have had experience with. But then also one that we don't talk about enough in the medical community is tick-borne vectors like Lyme disease, Babesia, Bartonella, Ehrlichia, Rocky Mountain spotted fever. These are bacteria and protozoa that are transmitted by a bug, by a tick bite, that can be, transmitted through dogs, cats, being outside in nature. And yes, people in a city can get a tick bite. It is, you are not immune by just your location, and you are not immune being outside of the United States. We know that it is a global epidemic, and certainly things like climate change are impacting that. We also know that different issues with the mitochondria can also create. Mitochondria has become a big buzzword on social media. Mitochondrial illnesses. Ultimately, a mitochondrial illness is looking at how the cell, the individual cell, behaves. And we're made up of trillions of cells. So when we start looking at how one cell behaves and how it may become dysfunctional, that's where we start talking about mitochondrial issues. So, the epidemiology of chronic inflammatory response is neuroinflammation. And that is one of the reasons why Dr. Amen has started an integrative medicine practice in all of his clinics, because we know that the brain is impacted by many different types of exposures. So, mental health isn't always just about depression and anxiety. It is about an underlying pathophysiology that may be creating anxiety, depression, or different types of symptoms in different patients. And we classify it in different ways. CIRS, WDB is water damaged buildings. We don't really say mold, we don't use that term, we use water damaged buildings. Think Katrina, right? Think the flooding in Houston or in North Carolina and Tennessee this past spring. or in the last couple of years. We think about Pfiesteria and cyanobacter. Believe it or not, that's what caused the fish kills um, in North Carolina back in the 1990s. Actually, when chronic inflammatory response was first discovered by Dr. Richie Shoemaker, it was all over the news here in the Mid-Atlantic, where actually the fish were dying in the Chesapeake Bay. And he discovered that it was this, it's called a diflagellate. It's a type of bacteria that was infecting the fish. People would eat the fish and then they would get sick. And the experience of having mold in these fishermen's environments, right? The different fishing huts, which are water damaged, homes that may have some water damage, they became very ill. And that's how he got to meet the president of the United States and, the mayor of or the governor of Maryland, and really kind of started this path back in the early 1990s of chronic inflammatory response. It has since grown. We know that post Lyme syndrome, and Lyme is really an umbrella term for all the tick-borne vectors. So it's not just about Borrelia burgdorferi, but again, Babesia, Bartonella, Rocky Mount, Ehrlichia, different types of bacteria. Post-COVID, we talk about, or long haul COVID. You may have heard of that term as well. And then, of course, chronic fatigue syndrome. One of the big ones, which people don't think about as much, but I have just recently because two of my neighbors have been bit by the brown recluse spider recently as they hang out here in the mid-Atlantic on the decking, and they create all those spider webs. They hide, right? And they're poisonous. They can create an inflammatory response. And then, of course, concussions. Think of children, think of adults who play different types of sports or who may fall and bump their head. That is potentially a priming event for neuroinflammatory illness. And then, of course, chronic stress, 24/7 stress. I say we shouldn't be running away from a bear for many, many days, many hours and days. But unfortunately, now with our jobs and these darn phones, right, we can communicate with each other more and more. Can Epstein-Barr cause CIRS? Absolutely. Absolutely. We see Epstein-Barr, reactivated Epstein-Barr, or any of the herpetic viruses create a chronic inflammatory response. Don't forget, Epstein-Barr is a herpetic virus, which we know about many of them. It's herpes number 4. So we do see many inflammatory events because of that. It's well published that COVID actually reactivates Epstein-Barr virus and creates many of this constellation of a multi-system body system, multi-symptom illness. So doctors have said to many of my patients, there's no way you can have this many symptoms. And my patients are like, no, really, I do. And I believe you. I believe you 100%. And then pre-staging a question, can oil well fires, yes, from Iraq and veterans cause? Yes, absolutely. It depends on the patient, the person who was asking the question, whether it be Crohn's or some other illness. But we do know that many of the Iraq war veterans back in the 80s and 90s, and of course, ones that are there now with the way they burned the petroleum, petrol solvents blues, was certainly a priming event as well. So the epidemiology for chronic inflammatory response for post-Lyme syndrome, PLS, one of the most important things that I remind patients is you do not have to remember ever getting a tick bite to know you've had a tick bite. You do not need an EM rash, that red bullseye rash. You do not need to have a rash to be infected with a tick bacteria or spirochete or parasite. And actually, as a matter of fact, in 2012, the CDC raised the estimate where prior to 2012, they said that maybe 3,000 people a year were diagnosed with Lyme or related illnesses. And then they actually increased it to over 300,000. That number has since gone up. I think it's now up to 400,000 cases per year. And one of the reasons is because of the testing. The testing here in the United States this is a very large conversation that we could have, and kind of a frustrating conversation for patients. But the two-tiered serology allows for roughly a 45% false negative test result, meaning 26% of the population actually has a false negative, meaning they get lost to treatment, or lost to the test and are not offered treatment. I actually had a patient last week who had a positive Lyme test, Western blot, and she went to infectious disease. It was beautiful. It was not that it was beautiful. I'm sorry that she had it, but the test was beautiful. I was like, this is perfect. Like you have Lyme. Like this is, we don't see this very much, a true test. And the infectious disease doctor said, oh, it's not right. We're not going to treat you. And I said, we give you what you ask for, and you're not even going to give the patient treatment. But yes, we do give them treatment. We base treatment off of testing and symptoms. So it's never just one thing. We do like to look at the whole holistic picture when it comes to treatment. So you have to ask the question. And this is something that I'm always talking about with patients. And one of the most important things I think that patients can do when they're starting to notice that they're not feeling well is to create a timeline. When did this actually start? What were my very first symptoms? Was it this year when I got COVID? Or maybe had I started not sleeping well 5 years ago or 10 years ago, right? I often hear from women, I had my uterus removed or I had a surgery for something and I've never felt the same since. I believe you 100%. I trust my patients' bodies and my patients' experience in their bodies. So, was this exposure, was it in the past? Is it current? Was the original infection treated or is it reactivated? For example, the question about Epstein-Barr. Yes, we can see infections become dormant. That is a term where they're not bothering anybody. And then all of a sudden, like when COVID happened, they reactivate the Epstein-Barr virus. They come out of hiding. And there is no difference between CIRS related to mold or water damaged building and actinomycetes and other biotoxin illnesses. So we see very similar constellation of symptoms when it comes to water damage, actino, Lyme, babesia, and chronic stress or concussion-like symptoms. This is the most recent research article that I published with Dr. Shoemaker and Andrew Heyman, looking at actually mold and actinomycetes in water damaged building that create chronic inflammatory response. This is specifically looking at genomic assays, which actually tell us what is happening right now to this patient. It's very interesting. My latest paper with Dr. Daniel Amen will be published later this year, and I'd be happy to come back and talk to you about that. It's going to be really exciting. But anyways, the case definition, and this becomes important because I do quite a bit of legal work in this space with patients with all different types of chronic inflammatory response, whether it be from mold, actinomycetes, or Lyme, or different types of inflammatory events. It has to do with the case definition. And in 2003, this was actually defined by the United States government as sick building syndrome. That's really important. So this is actually an illness complex. It does not have an ICD-10 code. So insurance, unfortunately, we have to code it a different way. But 2003, it was actually defined in the paperwork at the Government Accountability Office. There is a potential for exposure. It's a multi-system, multi-symptom illness, and a thorough evaluation. We do not leave one stone unturned. If you are a patient of mine, you know I ask a boatload of questions because there's always confounders. Always when patients say, well, wait a minute, could it be this? Could it be that? We always want to look at all the potential issues. And again, like I said, in 2008, the official definition of water damaged buildings and sick building syndrome was released. This is the case definition that we use in court, if you will, that allows patients to fight their case in the court system. Symptoms have to be similar to the published literature, which again, we go through those. Diagnostic criteria similar to the published literature. We're going to go through those in just a few minutes. The potential for exposure, so we do have to usually have testing of the environment. And then, of course, response to treatment. Do they get better? Do they get worse? Those are important criteria to consider. But again, there is a document that defines this illness complex that we use for all different types of patients. But the most important thing that I always like to ask patients, especially when they think it's a water damaged building, is do you smell a musty odor? Do you smell mold? Not we may not understand even what mold smells like. I certainly don't expect people to know what it looks like because mold is not always just black. We talk about black mold, Stachybotrys, but there's also Aspergillus, there's Chitonium, there's Willemia, right? Which they actually look green or white, some of them. They're not black. So you may not even understand what you're looking at when you see it, when you go through a home. One of my patients today was actually buying a new home, and she and I were going through the steps of how do you buy a home, and we were talking about the home she was going to put on retainer, or she was going to purchase, and we had a lot of questions about certain things. So again, we help in many different ways, very holistic treatment. And then we do testing, whether it be an environmental readiness moldiness index, it's called an ERMI, or a HERTS-Me. A HERTS-Me is looking at 10 or more, I'm sorry, is looking at 5 of the most common molds that can infect a patient. Their ERMI is actually looking at, I think, 26 different types of molds or indoor contaminants. But one of the most important things I like to remind patients is you really need a team of people around you when it comes to how do you heal from this illness. I am not a building expert. Certainly, I work with humans. I do not deal with animals because sometimes animals are sick as well. But you really need an indoor microbiologist or an IEP, an indoor environmental professional. And I will give you the website where you can actually look to find people who are trained in this topic to help you, right? To give you more answers, detailed answers. So what are you looking at right now? If you have been at Amen Clinic and you have had a SPECT scan, this may look familiar to you. This is actually a chronic inflammatory response brain, and you can see that there is scalloping along the outer edge. You can see the holes on the inside, or the indentations, if you will, on the inside, on the underside carriage of the brain, if you will. And then again, you can see much of the scalloping. When we look at the SPECT scan, really simple, they use the term toxin. And toxin is a really big word that means lots of different things to many different people. Typically, I like to shorten it to toxin is a bacteria, a virus, a parasite. It is an environmental exposure. It could be hormones to include the stress hormones. It could be any one of those things, or like I said, an environmental exposure as well from the military. We see that quite a bit. And again, this is the same patient, a different view. You can see the hot areas, the cold areas, usually consistent with specifically in the cerebellar region back here, the back of the brain. We'll see many areas of dysfunction in these types of patients. And what I like to remind people is when we do our assessments, I'm really looking at symptoms because the symptoms tell us about what part of the brain the patient is having an issue with. For example, the back of the brain, the cerebellar region, I often say it's not just about are you dropping things, are you clumsy, right? Because that's really what we traditionally used to think about the cerebellar, but it actually is higher order activity. For example, word finding, name finding, not being able to remember why you went into a room. It's kind of that clumsiness of thought, like, what am I doing? Right? Those are all different things that we see in the cerebellar region of the brain. So what do we need to have to diagnose chronic inflammatory response? So the SPECT scan is a very nice thing to have, or something like an MRI, neuroquant, we can certainly do as well. So there's a genetic susceptibility, it's called an HLA. And then there's blood work. There's regulatory peptides, which control many of the hormones in our system. For example, with MSH, or melanocyte stimulating hormone, it's the mother hormone that I call it. It looks at all the other hormones. And then different tests here as well, the C3A, the C4A, the MMP9. And I go through all of these with many of my patients when they are abnormal so they can understand exactly what these different terminologies mean and how it is impacting their brain. The trans growth factor beta 1, we actually look at that in all neurodegenerative diseases. It's never just about water damage or Lyme. It's also about different types of dementia, different types of neurodegenerative issues, different types of coagulation areas, issues. So it's more than just water damaged buildings. There's lots of different things. And recently, the paper that I'll be writing is on plasminogen activation inhibitor and the SPECT scan and different inflammatory markers, which is very exciting. Some people may have heard the term pulmonary artery systolic pressure if you are a cardiovascular patient. That may be something that you've heard of when you've had a echocardiogram. Those are things that I certainly do look at. I am a critical care nurse practitioner at heart, so I do look at cardiac. It's not just about the brain at the Amen Clinic. I look at the heart because whatever happens in the heart, believe it or not, the blood vessels are the same size in the heart that they are in the brain. Actually, the brain is even smaller. So whatever goes on in the heart, you can bet your bottom dollar it's going on in your brain as well. So when we start talking about flow issues, blood pressure, different types of vascular issues. That is a passion of mine because we know that those are the patients that typically aren't going to be getting better quickly. We need to do lots of work to help those patients. Think dysautonomia, different types of blood pressure, cardiac flow issues, and then VO2 max. I am a athletic coach. I enjoy coaching young adults, and my kids when they were in college. We were on the crew team, so we were very high cardiac ability coaching, right? So, and that is something that I'll actually be teaching at iLads in October. Everything we do for our high intensity athletes, we also do, believe it or not, for our chronic inflammatory response patients, but we do it at a much smaller rate because, again, it affects the mitochondria. When we start talking about someone who's chronic fatigue, I don't want them to do any exercise. If anything, I just want them to right? In not long distances because we don't want to exhaust them. And this becomes very important. Also, another passion of mine, it's a flow system, it's a flow state. And it has to do, again, with how blood moves through the system, how energy moves through the system, VO2 max. And then, of course, the diagnostic criteria is the exposure, right? Where is the exposure coming from? Of course, if it was in the military, we know that it may be at the time of their exposure, for example, with the Iraq veterans. But if it's here in the United States, is it in your home? Was it in your apartment in college? Was it, in your family home? Was that when you were exposed? And this is sometimes the hardest part is figuring out what the exposure was. Because there may be multiple exposures over a number of years, but there may be too many to identify when this all happened. And then also sometimes with pregnancy, when we think about Lyme or any of the co-infections, Babesia bartonella, were they laterally transferred through pregnancy? We do talk about that quite often as well, and we do see that. So the diagnostic criteria is always a conversation in the review of systems, but it's also a system cluster analysis where I go through every system, every body system. We do something called a visual contrast test that was created by the military, actually the Air Force in the 1970s. The Air Force calls it the Functional Acuity Contrast Test, or FACT. They do not call it the VCS test. However, they still do this test every day up until now, right? As of 2 weeks ago, I was actually seeing a colonel in the Air Force, and he takes this test whenever he goes in for one of his examinations. I make him do it as well. So it's something that we actively do. The thing about that is that it's got 50 years of reliability data. We know that it has about a 98% specificity and sensitivity, which is extremely high for being able to tell us what it's telling us correctly every time that you do it. And then the diagnostic criteria, the genetic susceptibility, and then the blood work as well. The system cluster analysis, yes, I have seen one patient with every single one of these symptoms. So typically what we say is for diagnostic criteria, if each one of these blocks was considered a system cluster, we'd want to see at least 8 out of these positive. However, like I said, I've seen every block positive and every system or every symptom as a complaint for one individual patient. These patients are typically quite ill, and they need a lot of support. And I am delighted that I am able to be here to support them. And the Amen Clinic is able to support them. So, oftentimes, and this is something that I have to remind patients, I have to remind their families, because this is not just a singular person illness, this impacts the entire family and their community as well. Is there's often poor cognitive function, brain fog, word finding, name finding, poor concentration, poor focus. Poor assimilation, right? Assimilation is being able to remember something that someone told you or learning. And it's not specific to any one biotoxin. You can get this from chemicals, solvents, glues. You can get it from water damaged environments. You can get this from a concussion. Again, a type of traumatic brain injury associated with chronic inflammatory response. So oftentimes we use this term called molecular hypometabolism, and that specifically has to do with the brain, where the brain is low metabolism, hence the reasons why we start talking about these cognitive issues, anxiety, depression, fatigue, poor cognitive ability. Um, and we see this with throughout all the CIRS patients. It's not just specific to one, and it's associated with mitochondrial energy production specific to aerobic glycolysis. Um, a little fun fact, if anyone wants to take you back to high school bio, is our cells do not run off aerobic glycolysis. That's not what we want them to run on. We want them to run on anaerobic glycolysis, right? That is the Krebs cycle. When we talk about anaerobic glycolysis, it's actually the Randall cycle, and I will be talking about that at ILADS, the International Lyme Associated Diseases, um, in October, specifically talking about neuronal energy or injury, rather, cognitive impairment. And something that I find really fascinating, again, part of that flow state is the pulmonary hypertension. We'll see many people, young and old, right? So it doesn't matter the age. They'll walk up a flight of steps and they'll say, man, I got to stop. I got to catch my breath, right? I'm so tired. Or they will just get up and walk across the room and expend all the energy that they have for that day because, again, they're noticing that this right-sided heart failure, not necessarily their feet swelling, but they'll notice this exhaustion that happens. Again, this is something that we see and that can be treated. This excessive inflammation and coagulation defects with immunosuppression persist beyond treatment of the initial infection. So, for example, if someone had a tick bite and we actually saw an EM rash and they got, by the grace of God, got doxycycline for 28 days, right? Or they had COVID, right? And they got Paxlovid or they got treatment, however, and they recovered. Everyone else in the house recovered, but they didn't recover as well as everyone else. We'll see this inflammatory response last after the initial insult has abated. So again, that can be confusing for people too, because people will say, Jackie, my entire family got it. Why am I the only one not getting better? Again, we know that there's usually a very predictable cascade of events that can happen. We just need to be able to put it together for that patient through blood work, review of systems, and then also the history. Okay, so now that we've diagnosed somebody, we've been able to identify the patient and treat them. We do use a variety of treatment protocols. This is the backbone of the protocol, but by no means is it the only protocol that we use. However, it is pretty comprehensive, and I think it's very good for an educational purpose to show that there's many different things that we do along the way. And treatment can last anywhere from six months to 18 months or longer, depending on the patient. Today, again, I saw a patient that I treated for 4 years about 10 years ago, and she came back today, and we got reacquainted, and we're getting her feeling better again. But the most important part is getting the patient out of exposure or figuring out the identifying exposure issue, but then also getting them on initial treatment. We call it a binder, and a binder simply does that. It binds to toxins in the system and it helps you flush them out of your system. And then we look at different types of gut brain axis issues, whether it be in the sinus cavity, it be in the gut, it be related to your hormones. And then we look at different types of inflammatory events in the body with TGF beta 1 and VEGF and MMP9. And this is something that I find to be quite true for all my patients, whether it be CIRS related to, like we said, post-Lyme, water damage buildings, concussions. Think PANS and PANDAS, pediatric acute onset neuropsychiatric symptoms, which again is a bacteria. We often look at it as a chronic inflammatory response illness. It's often like peeling the layers of an onion, right? Where all of a sudden, and this is the most important part, I think, when it comes to patient education, is what was the very first symptom that you had? Because that ultimately is going to be your tell the next time when we get you better and you start feeling unwell again. Maybe it's a headache. Maybe it's your right foot hurts. I have no idea. Maybe it's nausea. When you start feeling that again, I want to get you back on protocol now that you're living your best life. We always want to look at it as how do you peel that onion, but we want to remember the layers of the onion so that we can educate the patient on how to do this if I am not there or if they're living their best life and they get re-exposed. We must treat the mold exposure before treating chronic infections. We need to get the individual in a good environment for themselves. And that is not just their home, that's their school, that's their office, that's their place of worship. Whatever that means, we don't want them going into environments that may not be the healthiest for them. And again, that may be a challenge for some people. Like I say, I am a big believer of avoidance of certain situations, but not everybody can avoid everything all the time. They have work, they have kids. We have to teach people how to live with this illness in the environment that they have, right? And try to get them in the best environment possible. And 70, this is actually a dear friend of mine. He believes that 70% of his tick vector practice has mold exposure, right? So it's never just about Lyme or Babesia, Bartonella, but it's also about different types of inflammatory events, environmental events, mast cell activation, and then, of course, the limbic vagal nervous system dysfunction as well. We talk a lot about that, and our psychiatrists do a great job of talking about that, which is wonderful. So the biotoxin management, we talked about binder therapy very simply a few moments ago. Binder therapy literally does that. It binds to toxins in the system and it helps you clear them from your body. You need to reduce that inflammatory process. Typically, we do it with prescriptions, one of two. One is a powder, one is a pill. And what I do is most of my patients are wickedly sensitive. They are exquisitely sensitive to medication, or they have histamine intolerance or mast cell activation, and they can't do high doses of anything. They have to start off with micro dosing. And that's what we do. I say do a tweezer dose, believe it or not, tiny, tiny doses, right? And you slowly increase it as the patient can tolerate it. And you take it on an empty stomach. Roughly, you eat something anywhere from 15 minutes to 30 minutes later, a snack or a meal. And then you must take it away from other medications and supplements because, again, binders bind. And we don't want to, like I say, make expensive poop, right? That's not the goal. We want the binders to bind to the toxins and not to the medications and supplements. One of the most important things that I remind every patient before we ever start treatment, and I talk about poop all day long, every day, is are you going to the bathroom? Are you having a bowel movement? And this is one of the most challenging parts because literally for us to be able to drain the toxins from our system, we have to be able to pee and we have to be able to poop. Right. So, not to get too graphic, right? And with sweat, we want people who don't sweat concern me for the most part. Just FYI, I really want people to be sweating, peeing, and pooping. You really want your poop to look like this, right? Right in the middle, type 4, not type 7, not type 1 or in between. We really want, just nice and smooth and soft bowel movements. Now, not everyone's going to have a type 4 bowel movement every day. They may vary in between some of these, but again, we want them going every day. I had one patient a couple months ago who went to the bathroom once every 2 weeks. And I said, well, before I do anything, that's what I got to work on. I got to figure out that first, because if you're not going to the bathroom, we may just get you feeling better once we get you going to the bathroom. But we have to figure that out. Is there an allergy? Is there a sensitivity? Is there something else going on? We've got to look at all of her medications. Is there a side effect with the medications? But we got to get from each individual cell. If you're not detoxing each cell, and if you're not pooping, we can't properly open these channels to get the bad stuff out, right? So that's always an important thing to do. So if you're not going to the bathroom, that's the first thing we need to work on. And then we look at the sinus cavity. Believe it or not, the sinus cavity is one of the places that we find very treatment resistant bacteria. And in these patients who have chronic inflammation, you'll often see them, they'll stiffen their nose. They're always having a runny nose, or they always have a headache or a migraine because their nose isn't runny, but it's so stuffed up. And I never guess on patients. I'm not a guesser, right? I always like to test and treat and retest. We want to be able to make sure we get rid of these bacteria from the body if they have it. One of the things we know about multiple antibiotic coag negative staph, it's a staph infection we find in the nose. It actually lowers something called melanocyte stimulating hormone, which is the master hormone for all of your hormones, right? So estrogen, testosterone, progesterone. So when I see women, for example, who come to me, I love hormones. I love prescribing hormones. I love getting people to feel better, and hormones can sometimes do that for women and men as they go through transitions. But if they don't actually feel better with hormones after a couple months, I say, what's going on underneath that? You should be feeling pretty good. And that's when we start looking at other causes of some of their fatigue or other issues if they have this bacteria in their nose, because that could be artificially lowering their hormones, testosterone, estrogen, progesterone, cortisol, things that we want to consider. And then we also test for people who have gluten sensitivity. They don't have celiac, but they have gluten sensitivity, where maybe they could tolerate bread or different types of gluten products, crackers, and they no longer can do it. We actually test for it through blood work, and then we encourage a gluten-free lifestyle. Pretty much, I think all of Amen Clinic encourages a low gluten to no gluten to minimal white flour sugary foods. We're not fans of sugar here, unless it's natural sugar in fruits and vegetables. And of course, that we want to be measured as well, depending on the underlying illness that we're treating. And then we correct the hormone imbalance. So we were talking about the male and female hormones, DHEA, testosterone, estrogen, cortisol, and then progesterone. Oftentimes, one of the most important things, and I try to explain this in every patient, is when we start hormone treatment, I always want to test about roughly 3 months later, especially if testosterone and estrogen are involved, because there's an inflammatory process called aromatase where testosterone gets pushed into estrogen in both men and women. And that is the one thing that we don't want to happen, because testosterone being pushed into estrogen for whatever the underlying cause can actually create a more of an inflammatory process in a man or a woman. We'll see actually gynecomastia in men. We'll see breast tissue development. We'll see voice changes in men that have aromatase issues. We'll see low virility or low libido in both men and women, and many fertility issues, again, across men and women. I have seen aromatase in children in puberty, and this is something that we also deal with as well. And we check hormones through blood work, and we also check it through urine tests as needed. And then, of course, we do look at cortisone patterns. So one of the most important things that we do talk about quite a bit here at Amen Clinic, and then that I teach on extensively, is actually the vagal nerve dysfunction. The vagus nerve is cranial nerve number 10. In our noggin, we've got 12 cranial nerves. Everyone has them, or we should have them. And the 10th one is actually known as the vagus nerve, and it basically comes from the brain, and it's known as the wandering nerve. It basically goes throughout our body, innervating from our neck down, all of our internal organs, and it controls many of the different processes that we don't even think about in our body. Anyways, when we start to see it's called the HPA, the hypothalamus pituitary adrenal. Again, your adrenals in both men and women, we have two, one on top of each kidney. They wake us up, put us to sleep, and help us run away from a bear. We shouldn't be running away from a bear 24/7. It should only happen for a short period of time. But unfortunately, in this day and age, we do have lots of stress. And then the um, the it also impacts our fluid status. So being able to get our rings off, or when we wake up and we're puffy, that's actually your adrenal axis. And this is important because there's many things we can do for it. However, one of the most important things we can do is turn our phone off, turn off our TVs and our computers. As I know, as I'm sitting here, I've worked, 9 hours today, and here I am still sitting on the computer. But those are things that we need to actively work on to be able to decrease the stress in our lives. Because our adrenals, this is actually really important. When our adrenals go high because we're running away from a bear or whatever that stress is, Physiologically, our immune system always goes south. That's physiology. That's in all the medical textbooks. This is how stress looks. Cortisol goes up, the immune system goes down. Cortisol can only go up for a certain period of time before it hits its ceiling and then it goes down. And this is what we're talking about when cortisol and the immune system are very low. We often see that chronic fatigue, fibromyalgia, chronic inflammatory response patient. And this is what we're trying to decrease. Excuse me. So this just as a point of education, this is the cortisol curve. This is in theory what we want it to look like. We want it to be in this green zone, really beautiful, high in the morning, late at night, and then low at nighttime. We've seen this, all the way up here. Yes, this is one of my patients all the way up here. That is mean that their stress is so high, right? We need to bring that stress level down. And people who are typically this high, they all of a sudden become this low, right? Where actually they have a flipped curve. This is somebody who is awake during the nighttime and asleep during the daytime, right? So this is a flipped curve, we call it. And then this is someone who has no energy. They are flat. We need to do a lot of work on that hypothalamic pituitary adrenal axis. So one of the things we talk about, and actually Dr. Amen, I'm going to need to put a new slide on this. He actually is coming out with a new book later this year. I can't wait to read it on pain and the brain system. It actually is very similar to something like a dynamic neural retraining system, which is basically how do we look at other ways, non-medication ways of looking at pain, anxiety, and depression and treatment related to those illnesses. Something like a DNRS or a dynamic neural retraining, which is where we actually think ourselves well or we stop doing negative tendencies. We actually see that people have positive outcomes with just different ways of retraining the way our brain thinks. It's usually when we see something like this, it's not a question of if we do it, it's a question of when we do it. Because again, something like this, these patients are exhausted. We need to boost them up before we start retraining their brain. And then, of course, electrolyte and water balances. Like I said, the hypothalamus pituitary adrenal axis has to do with water flow. One of the most important questions I ask patients is, do you pee more than you should for what you drink? If the answer is yes, then there is typically usually a HPA axis issue, right? Now, if you drink a lot of water, that's normal. But again, we want to make sure that we're looking at all this good stuff. And then we have to correct the MMP9. MMP9 or matrix meloproteinase 9 is often associated with something called leaky gut. If you've ever heard the term leaky gut, leaky brain, leaky vessel, people who bruise all of a sudden and you're like, where did all these bruises come from? We'll often see that in many chronic inflammatory patients. And there's many different ways that we can do this. One of the most important things is fish oil. The Omega Power fish oil is fantastic. With chronically inflamed people, I typically say capsules twice a day. That's one of the most important things we can do. And then, of course, we want to look at vascular flow. One of the things that I've mentioned many times tonight is flow. How do we take care of how blood flows through the body? Again, if it affects the heart, it's going to impact the brain. And the brain vessels are just as small as those heart. And are we getting blood to where it needs to go? Again, the patients who are very tired, who can't walk up the steps. These are different things that we can do for the VEGF. And then I'm almost done, Charlie. I only have one more slide or two more slides. And then looking at complement activity. Complement activity has to do with different levels of exposure. You can certainly read about this. C3A is more about bacteria, while C4A is usually related to water damage building and have to do again with systemic cascading of the body. And then this is probably the most important thing that we talk about at Amen Clinic. One of the most important things is transforming growth factor beta 1, which again is a highlight. I'd be happy to come back and speak about this over in the winter or spring next year with our new paper that we're going to be talking about. It has to do with inflammatory responses in the brain and the body. Again, many different things impact it to include neurodegenerative diseases. And then, of course, looking at vasoactive intestinal peptide. This is the last step of our protocol. And this is honestly one of the best peptides that I've ever worked with. And yes, so I ran through the last few minutes very quickly, but thank you so much. This is my name, Jackie Meinhardt. This is my email address, and then this is also my email or my phone number at the clinic. I'm sorry, Charlie, that I'm running a little bit over.
Oh, no, no, no. I just wanted to thank you, Jackie,
Oh,
Dr. Meinhardt. This has been wonderful.
you can call me Jackie.
We do have some questions in the queue, and if certainly if others in on the call tonight would like to ask questions, please put them in the Q&A. The first question we had was, can oil well fires such as Iraq for veterans cause inflammatory responses such as Crohn's disease?
Absolutely, yes. We can actually see different types of chemicals, petrol, solvents, glues, especially from the military men and women, whether it be here in the United States or overseas on base. Well, and then outside of bases too, if they're in private industry, we'll see many different things cause this. Absolutely. Whether it be Crohn's disease or ulcerative colitis is dependent on the individual patient. But yes, we do see autoimmune conditions because of these certain exposures. Yes. And then Epstein-Barr, I see the next question, Charlie, the
Yep.
Epstein-Barr.
Mm-hmm.
Absolutely. We know that Epstein-Barr or herpes number 4 can cause chronic inflammatory response or systemic illness or systemic inflammatory response syndrome, SIRS, which is it does have an ICD-10 code.
Okay. It looks like the last question you have up is, I've always had a single nostril clogged. Could that be what you were talking about on the previous slide?
You know, something it actually very well may be related to something like that. It also could be related to different types of allergies or different types of exposures that you may be having. It also could be related to something from an anatomical standpoint, right? So think about deviated septums or sleep apnea. Those are things that we always talk about. Not everything is related to chronic inflammation, although many things are. I
Mm-hmm.
always like to be very clear with patients. We have to rule everything else out. Is there a deviated septum? Is there an anatomical issue going on? So I would certainly go to your primary care provider just to get a look, see what's going on in there. And then, yes, we can certainly test for something like that.
Next is, what about antigen therapy?
Yeah, so antigen therapy is something that we do offer depending on what the inflammatory cause is, depends on what we can offer to that patient. We do actually lots of testing at Amen Clinic to look at different bacteria and viruses and different types of parasites that we can provide treatment for, whether it be IV, whether it be under the tongue or as a pill. We certainly can do that as well.
How much does vitamin D3 help with some of the inflammatory conditions?
Yeah, so really interesting. Vitamin D is so fascinating. I promise every time I turn around, there's something new associated with vitamin D. And I like to say, I'm 51 and I grew up learning that vitamin D was really important for our bones, which it is, very important for our bones and strength and growth factors, but it's also really important for anxiety in our brain. So if we have a low vitamin D level, now, normal is 30 to 100. Ideal at Amen Clinic is 60 to 80. So if you have low vitamin D, like under 30 or even under 40, and you or your child have anxiety, I say the first thing you want to do is get that vitamin D up to 60 to
Mm.
80, because that may be a reason that you're anxious, right? That may be a reason for some of these mental health conditions. Let's get that number up. But really fascinating, listen to this, Charlie. One of the new things that we're learning is that vitamin D is actually really important for inflammatory processes in women and their menstrual cycle. So if you have a wonky cycle like endometriosis or different types of endometrial issues, always go to your doctor, get it checked out, but get a vitamin D, because we know that vitamin D regulates something called the renin-angiotensin-aldosterone system. Again, part of the heart complex, and that puffiness issue. Remember, we were talking about the puffiness
Mhm.
of the adrenal glands? And that's all immune system. So vitamin D actually regulates a woman's cycle. Wow. I know,
Oh,
right?
outstanding. Willow has the question. I know there's asbestos in my wall. I've heard if it is enclosed, it is safe. But there is a vent for the dryer that opens that wall right outside my bedroom. Should I worry about this?
Yeah, you know something? I am not an asbestos uh,
Expert?
expert, and I know that there's a lot of issues with asbestos. I have heard, Miss Willow or Willow, I have heard that asbestos, if it hasn't been touched, it's okay, but I'm not an expert in that field. I would want you to always check with your person, your people, an indoor environmental exposure expert or asbestos expert, because they may have a better answer for you. I don't know the exact answer. Always check on that.
Thank you. Kathleen, through what Aiming Clinics does, I've overcome several mold exposures. Tested clean last February. Recently, a building I work in had a sewer water exposure that came up through the floor. Besides mold, what else should I get tested for in terms of what can happen through sewer water exposure?
Great question. Oh my gosh. So that actually is something called an endotoxin. So endotoxins is a fancy term for what happens with bacteria when they whether it be in your body, so like that Marcons we were talking about in the sinus, that's technically an endotoxin, but sewage gas, and you know the pipes, if you look under your sink and they has that S curve in there, and how you can get off gassing up and it smells like sulfur, like rotten eggs. That's all endotoxins. And then of course the sewage leaks, that's an endotoxin as well. And that gaseous odor, that is so bad for people to be smelling, right, and being exposed to over time. If it happens, you get it cleaned up, you move on, obviously. But if it's in a building and it is flooding, right, that can become a very dangerous exposure for people. And they don't really think about that. They don't really, many people don't think about that, but that's something that we actively test for. And there actually is testing for this of the environment. It's called an endotoxin test through EnviroBiomics. It literally, you just take a sample of dust, you not even in the same room, and it'll tell you if there's endotoxins in the environment. That's a big deal. I'm sorry you're
Yeah.
going through that.
There was some scalping on my spec images that were this from Nehal. There was some scalping on my spec images. What would be the first thing to do to address this or understand the reason? And could that be due to a long history of strep throat and tonsillitis during childhood?
Oh my gosh, what another great question. So, when I was talking about the spec imaging before of that chronic inflammatory patient, you saw that scalloping, right? That scalloping along, the brain in theory, everyone says it should look like a thing of cauliflower, right? It kind of has those little grooves, but it really is supposed to be nice and flat, right? When you look at a picture of it. So that scalloping could be a toxic exposure. Like I said, toxins in the beginning could be a bacteria, it could be a virus, it could be
Mhm.
environmental exposure, and it could be related to hormones. Not to say it's not just your sex hormones, but it could be related to cortisol and concussions. So those are things that we all talk about. I cannot tell you by looking at your brain and the scalloping what the toxic exposure is. That's when you are referred to integrative medicine, and that's when we go to work. And that's what I try to figure out. So I can't tell you exactly what it is just by looking at your
Oh,
brain.
great. And this is amazing. By the way, Dr. Meinhardt, we have all but one of the individuals on this call who've been on the call since the very beginning. That's
Oh, yeah.
highly unusual for us to keep the audience that engaged for this long a period of time. And I have to say, it's because of the presentation you've made tonight that really touches, as you can see with so many questions,
Well,
touches
that's
upon people's
fantastic.
interest. Yeah.
I saw a question about CRP, the C-reactive protein. It was gone. Someone took it, someone it was up and then it came down. So
I,
C-reactive protein is one of my favorite things to look at with patients. It's gone, Charlie. So I think
okay.
someone took it off. But CRP actually is C-reactive protein, and it's a cardiac marker of looking at. So it's see, I just fell into it. It's a cardiac marker for sure. But again, what I'm trying to communicate with patients is this is so much more than your heart when we start talking about cardiovascular health. health. We talk, and it's the number one killer of people, hypertension. Whatever goes on in your heart goes on in your brain. So CRP is an inflammatory marker of your blood vessels, right? So if your blood vessels are inflamed, that has to do with endothelial dysfunction, and that is exactly what Dr. Amen and I are going to be publishing on later this year in the spring next year maybe. But I'll be talking about CRP and flow issues. I'm so excited to talk to you about it.
Yeah. Um, that's good that we have another one. Again, we're getting a lot of thank you so much for this amazing talk and for answering all these great questions. That's from Nahal again.
Oh, thank
Interesting talk.
you.
If you have the time, talk about lead for a minute. And I know we're at the max of the presentation, and I know it's 9:30 on your clock. So
I know, right?
if you've got the time
No,
for
I can talk for a few minutes. So lead is an industry. Well, lead has been around for a long time, right? So I'm again, like I said, I'm 51. We had lead paint back when I was growing up, right? We tested for it, but now hopefully we don't have too much lead exposure these days with the industry changing. But we do test for lead in patients quite often through heavy metal testing. Certainly, my family's generation, my dad's generation, so 80s, 90 years old, right? They had much more exposure to lead than my kids' generation in theory. But I do worry about people who work with computers, petrols, solvents, glues, people who do a lot of that work. There's potentially some chemicals associated with building electronics that I find really fascinating. And again, even though they're covered up, when you look at people who build things, they have like lots of outfits on, the PPE. But what's the airflow in those environments, right? How is the industrial complex how is the air moving around? But lead is something that's really fascinating, Willow. Um, we actually did a study through NIH with one of my previous clinics looking at something called chelation. And chelation is actually where we remove lead from the body through an IV solution. And patients typically come, and it actually helped with output, with cardiac outputs. We actually made people feel much better who had exposure to lead and mercury and different types of heavy metals. So that is definitely something. Um, Definitely work with a provider who understands lead in your area because there may be some things that they can offer to you as treatment.
absolutely. Thank you so much. This has been absolutely terrific. I've got to say thank you, thank you, thank you. There's
Oh,
been a
thank
lot of
you.
claps that have already happened. I want to take a moment to thank all of you for joining us tonight. I know it's for many of you across the country, it's as late as 9:30 at night, and we're just very, very appreciative that you took the time to be with us. Just so you mark your calendars, these talks are on the second Thursday of every month. Our next talk is going to be Dr. Daniel Amina talking about the power of hope and the future as he explores the complexities of suicide and the path forward towards healing. Through expert insights and compassionate guidance, he will discuss strategies for prevention, resilience, and fostering hope in the face of mental health challenges. But please, I know you all join me, and I can see all the clapping hands and the hearts that are going through this process of expressing how wonderful this session was. And thank you so much, Dr. Meinhardt.
I'm so delighted to be here. Like, I think it's just great that there's this community here. So, and I don't have any experience with the community except for tonight. So I'm delighted to be here. And if you ever want me to come back again, I'm happy to.
Again, I tried to put the way to join the network is going to amenclinics.com, going to resources, finding the alumni tab, and there's a link that I've tried to put into the chat, but obviously it's not working. Just go onto our website. Underneath resources, you tab down to Brain Warrior Alumni Network. That's going to bring you right to our page. All you have to do is click on Join Now, and that's how you can become involved in this network of the 120,000 fellow alumni around the world that are here to be of constant source of support and encouragement and fellowship for all of you. So thank you, Dr. Meinhardt. It's been absolutely a joy.
Well, call me Jackie. You know that, Charlie. It's good
All
to see
right,
you, sir.
Jackie. And
Have a
we'll
good
talk
night. I'm
more
going to
about getting
bed.
you all. Good night.
Bye.